Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. NIK NIKAM. I'm a cardiologist from Houston, Texas. In this presentation, we're going to look at the Doppler features of aortic stenosis. It is Aortic Stenosis Doppler 101. We're going to look at very basic information about Doppler, how to recognize the various components of the Doppler, and how to interpret that in terms of diagnosing the degree of aortic stenosis. So let us begin with the main feature presentation. So the topic is aortic stenosis, continuous wave and pulse Doppler 101. Here's an example of a pulse or a continuous wave Doppler placed right across the aortic valve, parallel to the aortic valve. As you can see, there is some mosaic pattern here. You can follow my arrow, and there is a significant a gradient. Normally, when we place a pulse Doppler here, if the patient has no aortic stenosis, it should be similar to the left ventricular outflow tract like here. However, if there is a significant stenosis of the aortic valve, we are looking at a 5-chamber view. This is the left ventricle, left atrium, right ventricle, right atrium, and this is the aortic valve. This is the mitral valve. This is the tricuspid valve. When we have an aortic stenosis, there is increased velocity beyond the aortic stenosis, which produces this significant waveform. And the denser the waveform, the higher is the gradient. The greater the velocity, which is like here expressed in terms of meters, 1 meter, 2 meters, 3 meters, 4 meters per second. And based on that, we can calculate the gradient across the aortic valve. There are multiple other parameters that we're going to be talking about when it comes to the aortic continuous wave Doppler. So let's continue with some of the important clinical features which account for those wave changes that we see in patients with aortic stenosis. A patient with critical aortic stenosis may have thickening of the aortic valves, sclerosis, and there may be calcifications and nodules, and there may also be some aortic regurgitation. There may be dilatation of the aortic root and the ascending aorta. There may also be associated left ventricular hypertrophy. Along with that, there could also be diastolic dysfunction of the heart function, which will be evident from the Doppler studies across the mitral valve. So we're going to focus on the aortic valve here. And when we are talking about aortic valve, it is very important to make sure that the beam is parallel to the aortic outlet tract. As you can see, it is sort of a modified 4 chamber view, where the transducer is twisted more towards the aorta and the right side of the heart. As a result, the aortic valve comes parallel to the beam, which gives the maximum deflection in the pulse Doppler and the continuous wave Doppler. As you can see, when you have dots with the two lines, that is a pulse Doppler, which is across this outflow tract of the left ventricle. And here we have a continuous wave, which is recording the gradient across the aortic valve. And here's an example of how to place your transducer, so the Doppler, so that it will be parallel to the outflow tract and the aortic root. It's two different views. This is a 3-chamber view, and this is a modified 5-chamber view. Okay, let's look at some of the components of the aortic continuous wave Doppler. As you can see, it looks like a cone, and sometimes you may be able to recognize a click and an ejection systolic murmur. As you hear with a stethoscope, that's what it corresponds to. You can see a click. Following that, we have a waveform which is recorded by the continuous wave Doppler, and the velocity of this is going to tell us how significant the aortic stenosis is. We are going to look at the beginning of the waveform and how quickly it reaches the peak. that is known as the acceleration time, which I'm going to show in another slide. Then we have the ejection time. That's when the ventricle is actually emptying into the aorta, and following that we have the recovery phase. If you have a patient with atrial fibrillation, it is not uncommon to see the gradient changing from beat to beat. In that case, you may have to average 8 to 10 beats to get the average mean gradient across the aortic valve. Based upon the gradient across the aortic valve, which is measured by the time velocity integral, that is, the time is this one and this is the velocity. The combination of time and velocity gives the time velocity interval, and we measure the time velocity interval using a continuous wave Doppler across the aortic valve, which gives the gradient across the aortic valve. Then we measure the pulse Doppler of the left ventricular outflow tract, which is going to be determining the pressure before the stenosis, which is reflected as time velocity integral of the left ventricular outflow tract. And using these two formulas, and we know the radius of the aortic root, and here we can measure the radius of the diameter of the aortic root, and half the diameter will be the radius, and based upon the radius we can calculate the cross-sectional area of the aortic root cross-sectional area, and velocity combination should be equal to the aortic valve area plus the aortic time velocity integral. I'll show you the formula in a minute. Here are different kinds of studies showing, a regular machine-based continuous wave signal, and we have to adjust this continuous wave intensity so that we get maximum possible intensity without getting any distortion. If the intensity is set to low, the same velocity may be looking very faint and it may be interpreted as not significant. Sometimes you may not be able to see the tips of these waveforms. The waveforms also differ in patients with like subaortic stenosis, or in patients with hypertrophic cardiomyopathy as compared to patients with aortic stenosis. In patients with hypertrophic cardiomyopathy, you can see a dagger-shaped waveform, whereas in patients with aortic stenosis, you see sort of a uniform waveform. A handheld device may be good for screening purposes, but it's not something I would use to determine the real degree of aortic stenosis and the condition of the heart valve. Now let's look at some of these numbers that we get on the screen when a continuous wave Doppler is recorded across the aortic valve. This is the aortic valve maximum velocity, which is here's aortic valve maximum velocity, which is 4.04 meters per second. Then we have the mean velocity of 2.98 meters per second. The mean velocity is throughout the duration, what is the mean velocity? The computer calculates this one. Then we have a maximum peak gradient of 65.35 millimeters of mercury and a mean gradient. It is a mean gradient that is used to determine the degree of aortic stenosis. If the mean gradient is greater than 40 millimeters of mercury, and if the velocity is greater than 4 meters per second, then it is supposed to suggest significant aortic stenosis. Then we have the aortic valve velocity time integral, which is 101.9 centimeters. Similarly, we calculate the time velocity time interval across the left ventricular outflow tract using a pulse Doppler, as I told you before, and then using that formula we can calculate the valve area. Here's another example of a waveform which is showing, and here's the maximum velocity of 4.58 meters per second, a gradient of mean gradient of 52.84 millimeters of mercury, and a velocity time interval or integral is 94.4 centimeters. We also measure the acceleration time, and in patients with severe aortic stenosis, the acceleration time can be increased. It can be greater than 60 milliseconds. As you know, in patients with severe aortic stenosis, we get a tortoise pulse or slow uprising pulse when you palpate the carotid artery. It's based on the same principle because it takes longer time for the wave to reach the peak because of the critical aortic stenosis. Heart rate is very important, and rhythm is also very important, as I said. And here's another example where a maximum gradient is 95 millimeters mercury and a mean gradient of 57.96. And based on that, we can calculate the aortic valve area. Aortic valve area here, maximum 0.461 centimeters per meter square. When there is aortic regurgitation, some of these findings may be sort of altered. That's something we need to keep in mind. And here is an example of the aortic continuous wave Doppler in patients with aortic stenosis with a velocity of greater than 6.78 meters per second. So the maximum gradient is 184 millimeters of mercury across the aortic valve and a mean gradient of 120, almost 120 millimeters of mercury. And look at the heart rate at 36. And here's the formula that is used to calculate the aortic valve area. We know the diameter of the left ventricle by measuring the distance from where the leaflets are attached here to the other side. The diameter is the left ventricular outflow tract diameter, and half of that will be the radius. Using the radius, we can calculate the area of the left ventricular outflow tract, and we know the velocity time interval. And in patients with aortic stenosis, we know the velocity time interval across the aortic valve. So the missing number is the valve area, which can be calculated by this simple formula. There's also a dimensionless index which can be used by just dividing the aortic time interval, velocity time interval by left ventricular velocity time interval, and I'll show you a chart where if it's less than 30, if it is 30% or less, it is significant. And here are the recommendations for grading aortic stenosis based upon the Doppler studies. If you have a peak velocity of less than 2.5 meters per second, if you have aortic sclerosis, the velocity may be 2.5 meters or less. With mild, it could be 2.6 to 2.9, and with severe, the velocity is usually greater than 4 meters per second. The mean gradient is usually more than 40 in patients with severe aortic stenosis. Between 20 to 40, it is considered moderate aortic stenosis. The mild aortic stenosis valve area is greater than 1.5. The moderate aortic stenosis is 1.0 to 1.5, and severe aortic stenosis is less than 1 centimeter square. And when it is indexed to the body surface area, if severe aortic stenosis is considered if the valve area is less than 0.6 centimeters square. And when we just consider the time velocity, just the dimensionless index, anything less than 0.25 is considered severe aortic stenosis. And here is another chart from the American Heart Association, European Society of Cardiology, ACC. They have the same chart which is depicted here. I was talking to you about the acceleration time and the ejection time. In patients with severe aortic stenosis, it takes longer time for the wave to reach the peak. As a result, the acceleration time will be longer and the ejection period will be slightly shorter. Look at this acceleration time, which is much longer compared to this acceleration time. And of course, if you look at the gradient, this is close to like 3.75, and this is like close to 3.25, something like that. So I already mentioned about how to calculate the aortic valve area. We take the left ventricular outflow tract VTI and left ventricular cross-sectional area. And here the question mark is aortic valve area, which we don't know, but we know aortic valve velocity time interval. So using this formula, we can calculate the aortic valve area. So ladies and gentlemen, this is a quick synopsis of the Doppler 101 in patients with aortic stenosis. I hope this has been educational to you, and please do subscribe to the YouTube channel. We have more than 300 videos that are of importance to the clinicians, patients, and the public. And I will see you in the next presentation. Thank you so much.